Let's go to undoubtedly the highlight of the year, bigger than ESMO, was the Uromigos meeting.
Yes, I noticed your shirts.
Yeah, I still got the shirt.
Uromigos meeting. So we started with bladder cancer. We talked about perioperative therapy, right? Niagara and otherwise.
We talked about lots of different things, but what I'd like you to start with, we did I think it was a live session on sequencing immune therapy and in renal cancer. And I think it was a very lively debate.
It was. So we sort of recapped both the CONTACT 03 and TiNivo-2 data, which were flatly negative. IO-TKI versus TKI in an immune-experienced population. Similar trials, not identical, but in essence the same. Flatly negative. No response rate advantage, no PFS advantage, no OS advantage, no CR advantage, no durability of response. Like, you could sort of make an argument, well, even if the whole group doesn't benefit, again, the calling card of immune therapy is, oh, there's this subset that does really well. You didn't even see that. No. It was all TKI based, right? Yeah. And in TiNivo, with a lower TiVo dose in the combo, we saw actually a lower median PFS.
Yep.
So it tells me the whole efficacy is driven by the TKI, right? It only reinforces that point. Despite that, the practice of giving sequential immune therapy, while I think it's less as a result of these trials, has not gone away. I think one of our polls showed 20% of people are still sort of doing it in practice.
In metastatic disease.
In metastatic disease. Yeah, and we've made up this arbitrary, well, as long as it's 12 months.
This year things
as long as it's 12 months since the end of immune therapy, and people point to T-cell receptor occupancy and drug half-life and blah, blah, blah.
The solar system has always had a crucial role to play. In the efficacy of immune therapy.
It's completely made up. So I have a very strong position on this.
I wonder if Jupiter's moons have any role to play.
Don't interrupt me. I have a very strong position on this, that we're harming patients if we're giving them ineffective drugs, right? If there's no proven benefit, then all you're doing is exposing that patient to risk.
Okay.
Including potentially life-threatening risk, right? There were 3 toxic deaths in the CONTACT study, right? Okay.
But it was a big study. It was on 3%. It was 3 out of 500.
If you're one of those 3 people, it's a bad thing, right? And we shouldn't... Listen, if there's efficacy, then yeah, patients and providers are willing to accept toxicity. No question about it, right? I mean, in the Niagara study, right, there was some treatment-related deaths, I believe, right?
Less than 1%.
Right, but it was still there. So, but again, in the context of a...
Same in both arms.
Fair enough. In the context of a survival advantage.
No increase with
and I'm not picking on Niagara.
Yes.
In the context of a survival advantage or efficacy in general, we will tolerate toxicity and figure out how to manage it, like we talked about with T-cell engagers. If there's no advantage, then it's all toxicity, right? If there's literally the flattest negative trials we've seen in kidney cancer in some time, right? But people say, oh yeah, those are negative, but I'm going to still do it because I've made up this 12-month, because it existed for cisplatin and ovarian cancer or something. I think it's beholden on us to either test it, prove it negative, and stop doing it, or just stop doing it now.
While you're riding your high horse, maybe just get over a second and talk about the adjuvant setting. So re-challenge in the adjuvant setting. I think most people wanted to re-challenge after a year in our
want to, but not based on any data.
Yeah. No, I agree. Look, I feel I'm anxious if we do big randomized trials
and then ignore
the results.
Yeah.
I don't think that's a good. No,
right.
It's more than just. It's not good for patients. It's not a good look for the whole thing. Because what's the difference between that and just
why
making,
do them? Yeah.
Well, not only that, give mistletoe or it needs mistletoe. There's
shark cartilage.
Yeah,
right.
There's no data on shark cartilage. At least there's that. But where with this, we know it doesn't work. We still do it, and that has I have concern.
In fairness, there was a small percentage. There was like vanishingly small on CONTACT, and small on TiNivo-2. The proportion of patients who their eligibility for the trial was based on adjuvant pembro.
Yes, and we don't know that question, but most people didn't want to ask the Len-Pen versus...
But most people, they don't want to do the trial, but yet they want to give it in practice, therapy, so that doesn't make sense.
But maybe time will change. Maybe the data's quite immature, and maybe as time matures, people will look at it and think, actually, we're not getting any benefit from here. This is...
And I think part of it is, I'll call it the Dave McDermott effect. We know the other option is a very unexciting single-agent TKI that's not curative.
Yes.
So if I have an unexciting option or an exciting, potentially curative one, even if theoretical, this is just human psychology, I'm going to choose that one.
And Mike Atkins talked about, and Hans Hammers at our meeting talked about giving Ipi-Nivo post.
So I think the CTLA-4 question is unanswered,
so this is sequencing Ipi-Nivo after pembrolizumab.
Right, it's call it Ipi-based therapy after adjuvant pembro or PD-1-based therapy in general. There have been 3 trials that in the metastatic setting started with Nivo, added Ipi at progression or lack of response at a certain time point. My interpretation, mostly progression, half to 2/3 had primary progression, 10% response rate, and CRs that I could count across all 3 trials on one hand. There have been one study and one retrospective experience of Ipi-Nivo given together in a salvage setting, and again, minimal activity. Hans and David made the point in our meeting, well, even if it's minimal, it's their only chance at durable remission. Right?
You didn't love that.
You
didn't love that.
Again, it's sort of
I've got to tell you, Brian, it was a couple of months ago, but I remember sitting there thinking, you're not loving this.
It's just, again, it's sort of one of those wishful thinking, sort of like, I'm going to give this broadly inactive therapy because there might be this many patients across a few hundred who achieve. And I understand it. Again, I understand the allure of it, but to say that it's a standard, I don't think is the case.
Part of me, I love the positivity that they have around it. And so part of me thinks that aspiration saying we need a cure and these patients will need a help and we may be lucky with a few. I love that aspiration. But I also, in the back of my mind, think sometimes I think you're going to get one good go at PD-1 therapy.
Agreed.
I don't think CTLA-4 adds that much. We know the adjuvant Ipi-Nivo trial, if it was magic, it wouldn't have been flat negative at 1.0. And I think the role of Ipi, I'm very happy to give Ipi-Nivo frontline metastatic disease, and I think for some patients it's great. Whether it's a lot better than single agent Nivo or Pembro, well, the 8x8 trial, we haven't seen the result of that yet. But the question then, which is a more complicated one for me, is it actually sometimes you just need to say, patients, unfortunately this hasn't worked, and we've got these oral tablets that you can take, and they'll make you live 2 or 3 times longer than doing nothing.
Yeah.
And that's a more difficult conversation, but that's currently where the evidence is, I'm afraid.
No, I feel that's what I'm saying. It's not a data-based discussion. It's, I'm uncomfortable telling a patient, I now can't cure you, but I can control disease, et cetera, cost of toxicity. It's a more uncomfortable for the provider. It's far more interesting, far more appealing to say, listen, this probably won't work, but if it does, you can have a durable remission. Like if I'm a patient, like sign me up for that, right?
Look, it's Christmas, and we have to end on a positive note.
Okay.
So we had an ADC session at Uromigos as well in urothelial cancer, and we had a broad discussion around, we've discussed EVP, and I'm not going to go through that again, but we also talked in the perioperative session about potentially curing bladder cancer with immune checkpoint inhibition, PD-1 combinations, PD-L1 combinations, Vulgar, 303, 304, B16, all these randomized trials in this space, B15, all these randomized trials in this space, and that was and we've done a podcast and a video on that, and we're not going to go through it right now, but we should just say that there are a series of new ADCs coming through, disitamab vedotin, HER3 ADCs, there's a second generation of TROP2 ADCs, DDXD, for example, other TROP2 ADCs, potentially with different toxicity profiles compared to sacituzumab govitecan. We saw combination data for some of these newer agents with PD-1, and it doesn't look like the payloads are all the same, and it doesn't look like the targets are all the same. There's some personalized therapy, and we saw that with the HER2 ADCs, TDXD, disitamab vedotin, response rates of about 50%, which is high, EV 40%, cross-trial comparison a bit futile, blah, blah, blah. EGFR, HER3 ADC, Chinese data, response rates of 40%, but also in the second line it was something like 75%, something crazy like that. We don't know enough about that 22 patients, all the caveats that go with that. New combinations, new ADCs coming into the space, new generations of Nectin-4 targeted ADCs. We talked about the bicycle drug and the bicycle technology associated with that. Also, Loxo had a drug with Nectin-4, but with topoisomerase rather than MMAE as the payload. I thought that was really interesting. We talked about the PD-L1 biomarker. The Nectin-4 biomarker with immunohistochemistry not really being very relevant because it's so broadly expressed, but in where it's less broadly expressed, such as HER2, maybe other areas too, it has a role to play. So I think that was a big session for us. I think it was our most popular tweet from our Uromigos account of the year so far. So that was and then the last thing, of course, let's round it up with the Uromigos Cup, and let's start with the Japanese team. Yeah,
Team Japan came all the way over. So we had an international competition to see which international team we'd fly into Nashville to participate in the Cup this year. Canada, Netherlands, Germany, and Japan. We did podcasts with each, and then we had a Twitter poll, and the Japanese came out ahead in that.
Yes, they did.
We informed them that we were inviting them to National. Within 24 hours, they all had plane tickets.
Amazing. Very organized.
It was very organized. hugely enthusiastic, and I think it was definitely a highlight of the meeting.
Amazing addition to the meeting.
Amazing addition. Semifinal versus Uramigas, which is our Spanish language effort. We sort of mixed and matched a little bit. Maria Borlon was there. Laurence, was on the team. And the Japanese... Andrea Apollo, yes, of course.
It was a fabulous team.
Fabulous team. Spirited competition. There were questions about the scoring system. I don't want to get into that.
I was confused about the scoring system as well, but I was doing the scoring.
Yes. And the Japanese
But the Japanese were fabulous.
They were both teams were fabulous.
They did know the Taylor Swift trivia. They were very good at that.
They did know that Taylor got her start at the Bluebird Cafe in Nashville. That was probably the most impressive answer that came out of the meeting. And then they faced off against Team USA, which was sort of a modified Team LA, who won the first year.
Well, we felt that Team LA was not big enough to take on the whole of Japan. We felt we had to get the whole of the United States together. So we flew Dave McDermott in.
We roped David in. Yes. And
who moaned throughout the whole competition, as far as I can remember. Yeah.
And then they came out ahead on the Uromigos Cup. But
it was the American team in the end.
Yes.
No
bias. There was no bias there.
Do you want to go and get the cup right now?
I can't. Why don't you go get it, since I have a bum leg?
Oh, okay. I can get the cup. Here we go. Wait a second.
See where it is.
Fabulous. It's on its way to, I think it's Boston first, isn't it?
Yeah. Well, you can see this is last year's winners, 2023.
We
need
get on with that a bit. Let's put that down there for a second. Next year.
Let's talk about what we're looking forward to next year, 2025.
So we have no idea what's going to happen. We're not going to talk about anything that we know is going to happen for sure, and we're just going to talk.
We're not going to talk about results, just trials.
Just in broad terms.
I can start with RCC. You mentioned 8x8, which is this European effort of Nivo versus Ipi-Nivo, sort of small randomized study. We've been kind of waiting for the data. Maybe this is more hope than anything that we'll see that to clarify the role of Ipi in this disease. I have a feeling it won't actually do that, but I'm hopeful we'll see that data. We have the 011 study, which is lenvatinib belzutifan versus cabozantinib in a second-line setting. I have a feeling those data may be out. I think, in terms of the timelines, we may see that data again. Does belzu have a role in combination in an earlier stage disease? I think those are probably the two biggest trials that we would expect in the next 12 months. Can you think of anything else in kidney cancer?
No, I don't think so. And I think in bladder cancer, we'll probably see some more neoadjuvant trials coming out, on perioperative studies. I think that's going to be exciting, and we'll see some more ADC data, of course.
Yeah, those are the two big.
And then in prostate cancer, there'll be more lutetium, more radioligand data. We're going to see a lot more T-cell engager data during this period of time. And I'm looking forward to seeing some androgen degrader data. We didn't talk about androgen degraders. We
talked about a little bit last year.
Yeah, we had a podcast with Dana around that.
Yeah.
But I'm excited about that new target. So new targets in prostate cancer.
Yes. Should be a big year. Always a big year.
Should we call it?
Let's call it a day.
Happy Christmas.
Merry Christmas.